welcome to Voices of Wisdom, TIRO's podcast, designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. So in today's episode, we're going around the world in 3 clinical cases. I am so excited to have 2 special guests. Dr. Fabian Pitoia is an internationally recognized thyroid cancer researcher and chief of the thyroid section at the University of Buenos Aires in Argentina. Dr. Iwao Sugitani is a leading expert in endocrine surgery and thyroid cancer from the Nippon Medical School in Tokyo, Japan, and particularly known for his work on active surveillance and risk stratification. So together, we are going to explore 3 unique thyroid cancer cases to dive into the nuances of management strategies for low-risk, intermediate, and higher-risk patients. We're going to start, and I just really want to thank Dr. Sugitani again for joining us so early in the morning. Arigatou gozaimasu. And Dr. Fabian Pitoia for joining us so late in the evening. Buenas tardes.
Buenas tardes.
Ohayou gozaimasu. The pleasure is mine. Thank you for having me today.
Well, we're going to dive right in then on our first case. It's a 49-year-old female patient who comes to your clinic with an incidentally discovered micropapillary thyroid carcinoma. It was discovered on a neck ultrasound that was done because she had a sore throat. And it's a 7-millimeter lesion in the middle of the lobe. Cytology is Bethesda classification 6, papillary thyroid carcinoma. There's no extrathyroidal extension. There are no lymph nodes on the ultrasound. So I'm going to start with Dr. Sugitani, Iwao. What do you tell that patient? And do you suggest active surveillance? And then a corollary to that is, do you let the patient choose? What do you look at do you suggest other options?
First, I will explain the concept of active surveillance based on the consensus statements produced by the Japan Association of Endocrine Surgery in 2021. I will begin by discussing the frequency of micropapillary thyroid carcinoma found in autopsy series and highlighting recent concerns about overdiagnosis or overtesting with ultrasound and overtreatment. Following this, I will show the data comparing active surveillance with immediate surgery in terms of oncological outcomes, unfavorable events, surgical complications, quality of life, and cost. Supposedly, I will then emphasize that the management plan should be determined by the patient's autonomous decision. But actually, in my own clinical practice, I will recommend active surveillance as the first choice approach for cases like this. While I acknowledge that there are differences in practice preferences among facilities in Japan, if the patient opts for surgery after receiving this explanation, of course, their choice will be respected. As for adoption rate of active surveillance, at the Oncology Referral Center, Cancer Institute Hospital, where I started a prospective active surveillance study in 1995, over 90% of patients chose active surveillance in the end. In contrast, my current institution is a university hospital, and we also perform remote access thyroidectomy. So the proportion of patients choosing immediate surgery is about 20 to 30%. In this particular case, the patient is 49 years old. But even in much younger patients, such as those in their 20s, the lifetime risk of disease progression, the probability of requiring surgery by age 18, is estimated at less than 50%. Thus, I would say active surveillance remains a viable option. However, I would also ensure that they understand that the observation period could be very long.
Oh, wow, that's impressive. So patients can spend their whole lives on active surveillance up until 80 years old or even longer, because life expectancy is really long in Japan. And so less than 50% of patients are actually going to be operated on.
Yes. But there are no evidence for the younger than 20 or 18 years old. So that's a little bit problematic, I think.
So we have to be patient. Fabian, what's your take on that for this kind of a patient, 49 years old, micropapillary?
I think that this is an ideal patient for active surveillance. And of course, I would offer this patient the opportunity to undergo active surveillance, given all the evidence we have right now at this moment after more than 30 years. This was begun in Japan by Dr. Miyauchi. But, here in Latin America, things are a bit different. And we have been doing studies. We started doing active surveillance in 2014. And the acceptance at that time was only 25% of our population who was candidate for active surveillance. And it didn't change in 10 years. We repeated this study this year, and we did not find any change in the acceptance rate. So, of course, this is a very candidate patient to active surveillance. And sometimes what we do is try to avoid the initial sudden treatment or sudden decision from the patient. So we say, please, let's take some 2 or 3 months to understand how do you feel with the idea of the active surveillance. If this idea of you having a tumor that probably won't produce anything in your body and won't change in 90% of patients remaining with the same size, please, let's try to figure out how do you feel with this situation. And of course, after these 3 or 6 months, we reevaluate the patient and we want to know how the patient felt. As I said before, 75 of our patients are maximalists, and they would really move to probably a surgery.
That's a big difference in across the globe. Fabian, and this is kind of off the cuff. Is it because people don't want to travel maybe to do this surveillance, or it's just seems like too much for them to do it and they just want to be rid of it? Do you think or is it just a matter of patient education?
I think that it doesn't have to do with patient education either, because even educated patients do not want to have a cancer in their neck. This is the idea I perceive from these patients. Although they are very aware about the no progression or the indolent behavior of these tumors, the only idea of having a cancer not being treated, and this is something that probably is completely different from the Occidental patients. I mean, even more from Latin America, where cancer has a very strong meaning. Probably these patients will not want to undergo active surveillance. So this is a very challenging situation for us in Latin America, because we have been doing active surveillance, and in these 14 years, we only had 100 patients in our cohort of our study.
So there really are big cultural differences that a lot of us are not aware of. That's really fascinating. Well, just the next question on this, though. So if the patient says,
yeah, I just want surveillance. I don't want to go to surgery right away. Do you look at TSH levels when patients are on active surveillance, or do you treat them with thyroxine therapy to put TH levels into a specific zone? Iwao, do you have a take on that?
Okay. Before that, the adoption rate of the active surveillance depends on the institution, even in Japan. So some hospitals had a lower rate of the adoption rate of the active surveillance. And our data showed that patient anxiety is released over time. And so the first 2 or 3 years is the key to continue active surveillance, I believe. Regarding TSH suppression therapy, Dr. Miyauchi from Kuma Hospital have recently reported its potential benefit in inhibiting disease progression, particularly in younger patients. However, based on my own research at the Cancer Institute, I did not find the correlation between TSH levels and the progression of micropapillary cell carcinoma, even though that cohorts were rather older than other studies. But I don't actively recommend TSH suppression in my practice. Personally, as I'm a lazy surgeon, I hold the view that if doing nothing is an option, then we do nothing. Having said that, we are planning to initiate a multi-center prospective study in Japan to evaluate the efficacy of TSH suppression therapy in preventing progression during active surveillance for low-risk papillary cell carcinoma.
Great. So if you can do nothing, do nothing. That's very nice. So maybe it is a question of that's you're saying that's maybe habits and just getting used to the idea of it. Fabian, for patients in your practice who are on active surveillance, do you look at TSH levels?
We are very aware from the studies Dr. Iwao mentioned before. And we follow the suggestion of Mike Tuttle in an editorial published in Thyroid after the study of Dr. Miyauchi. Dr. Tuttle says that probably a nice TSH level would be less than 3 milliunits per milliliter. And so sometimes if we have a TSH upper the normal limits, we would treat a patient with a subclinical hypothyroidism that we usually wouldn't treat. But with an active surveillance, probably we are prone to do treatment in these patients. Of course, the evidence is low, and we are aware about that, but we want to keep a TSH, at least a normal TSH for these patients.
Okay, so we don't want them to be in hypothyroidism, or we don't want that TSH to be too high. That's a really great point, to not overtreat them with thyroid hormones, but just make sure that the TSH is normal. I think that's something that you guys agree on. That's really very interesting. So I'm going to go into the second case. It's a 55-year-old male patient who comes to your clinic with, a nodule that was incidentally detected on a neck Doppler ultrasound. It's a 15 millimeter lesion. And again, it's papillary thyroid carcinoma, Bethesda 6. So 15 millimeters. There are no suspicious nodes or overt extrathyroidal extension on ultrasound. And so I'm going to ask Fabian, the first question is, do you propose an upfront lobectomy on this patient?
Well, I think that for this patient, I try to explain that whether we choose even active surveillance, because it could be an option for the patient with an ideal candidate with a thyroid nodule in the middle of the thyroid gland. Even with 15 millimeters, we could, with data published by Dr. Sugitani, showing that even for T1B tumors, we can choose active surveillance. We are prone to offer active surveillance, and we explain the 3 pathways, saying whether we choose active surveillance, we choose lobectomy, or we choose total thyroidectomy, probably the final result of a structural incomplete response, lymph node metastasis, will be the same. And it is around 2 to 3% for these kind of patients. So these pathways have a common end. And we let the patient choose explaining each of these pathways, which probably drive the patient to the same outcome.
Great. So that's a great point. This is going to be a tumor with a really good prognosis, whatever we do. Dr. Sugitani, what would you propose to this patient?
Well, the age of 55 is a borderline case in UICC, HSCC, TNM staging. And as Fabian thankfully said, personally, the active surveillance is an option. But for clinical T1B, M0 papillary cell carcinoma, Japanese guidelines, like the ATA guidelines, classify it as a low risk category, regardless of age, and basically recommend lobectomy.
So you would be more in favor of a lobectomy, given his age in particular?
Regardless of age, basically lobectomy, but if the patient want to have active surveillance, we permit that option.
That can also happen. Well, that's a really great that we have all those options, but it makes us take a lot more time explaining things to patients, I think, too. So the second question on this is that the patient has opted for lobectomy, and then you get the final pathology report back, and it says it's papillary thyroid cancer, but it has microscopic extrathyroidal extension, and there's some vascular invasion, but it's less than 4 images. So it's what we might call an intermediate risk lesion. Fabian, would you do anything more for that? Would that raise any red flags in your mind?
Well, this is a very difficult situation because at this point if we follow what we used to do, we probably will complete the total thyroidectomy in the patient and be very reassured that the thyroglobulin level is less than at least 1 and everything is perfect for this patient, and we can define the patient have an excellent response to treatment. But now we are in the middle of this pathway where we could evaluate the dynamic risk assessment and then define what we do with the treatment. So we know that thyroglobulin probably will not be very useful for the follow-up of these patients. We'll have to follow this patient only with the ultrasound, looking at the multifocality and bilaterality of this papillary thyroid cancer, and mainly looking for the higher risk of recurrence that could be around 10% probably or even more for an intermediate risk of recurrence. So we need to explain the patient this risk, and most of our patients, when we explain the situation, probably choose to move to total thyroidectomy and complete total thyroidectomy, and we can reassure them with the thyroglobulin level.
Great. Iwao, what do you think about that? Would you go further? How would you counsel this patient?
Even if minimal exercise extension or vascular invasion is found in the pathology results, usually completion thyroidectomy is not recommended for papillary carcinoma. However, for follicular carcinoma, recommendation depends on the number of vascular invasions, and completion thyroidectomy with radioactive iodine therapy may be advised for case with 4 or more vascular invasion sites. In fact, with this year's guideline revision in Japan, even for intermediate risk papillary carcinoma, lobectomy has been set as the first choice for unilateral cases. Although there are slight differences based on age, the 20-year disease-specific survival rate for intermediate risk cases is 93 to 100%, and the distant recurrence-free survival rate is 73 to 98%, which are favorable and show little difference compared to low-risk cases. That's the national.
Thank you for tuning in as we navigate 3 real-world thyroid cancer cases, examining management strategies and the cultural and clinical factors that shape care worldwide. Due to the depth and importance of our conversation today, we've decided to extend our chat into the second part to ensure that we cover everything thoroughly. So don't go anywhere. We'll continue our discussion in part 2 of this episode, where we will delve deeper into this subject with our esteemed guests, Doctors Fabian Pitoia and Iwao Sugitani.
If you have any questions or suggestions for future podcasts, please don't hesitate to email us at voicesofwisdompodcast@gmail.com. We have an exciting season coming up. Please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit tyro.expert/subscribe or click in the link in the description.
So stay tuned for part 2 and join us as we unravel more insights in these clinical cases.